Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. Today's episode features content from a comprehensive online educational program titled Navigating the Nexus of Addiction, HCV Infection, and HIV Infection. During this podcast, Dr. Sandra Springer from Yale School of Medicine and Dr. Christian Ramers from Family Health Centers of San Diego discuss the benefits of and the need for an integrated approach to providing addiction and infectious disease care. For more information on Dr. Springer and Dr. Ramers, and for a link to the full online educational program, including downloadable slides specific to today's discussion, please visit the show notes for this episode. Now let's get started and hear what Dr. Springer and Dr. Ramers have to say about this important topic.
So first, it's important to know what we're trying to achieve in taking care of an individual with HIV. Here, this represents the HIV cascade of care among individuals who have self-identified as injecting drugs who have acquired HIV, and this is representative from the 2016 CDC data in men and women, and looking at the cascade of care. Our ultimate goal in treating HIV is to achieve viral suppression. Here in both men on the left-hand side represented of the slide and on the right-hand side are women with injection drug use. You can see that only around 50%, upwards of 57% in 2016 had achieved viral suppression. So we're far off that mark of achieving 100% viral suppression in line with the goals of the administration in the United States of ending AIDS. There are two reasons that we want to achieve viral suppression. One is to reduce morbidity and mortality of those individuals living with HIV, but two, to decrease transmission to those who are partaking in high-risk behaviors. So if individuals are not able to achieve viral suppression, we're going to have a hard time in ending AIDS in the United States, in particular this population.
So speaking of the cascade of care, we use this kind of model to show how our systems are doing. We use it with HIV as well as hepatitis C. And what I'm showing you on the slide here is data from the National Survey on Drug Use and Health, which really estimates the cascade of care for opioid use disorder. And it gets a little depressing presenting these over and over because it shouldn't be a cascade, it should be a continuum of care, but because of the way the numbers look and how precipitously they fall from left to right, it does end up looking like a cascade. But just to walk you through the numbers, we have estimated about 2.5 million people in the United States with severe opioid use disorder. A good proportion of those, probably more than half, are diagnosed, but then it drops off further from there where you see a much lower number that are engaged in care and then retained in care for at least 6 months, probably hits really less than a third of those who are engaged. So really not hitting the goals that we want in order to address the problem of opioid use disorder in our country.
Yeah, and I think it's important to note when we say engaged in treatment, it's really effective medication treatments for opioid use disorder, and very few are being prescribed them. And even worse than that is that very few people are staying on treatment. What we wanted to show here is that if you can treat their opioid use disorder with an FDA-approved medication for opioid use disorder, and in particular here we're talking about individuals living with HIV, that you can achieve two goals with one. One is you can obviously reduce overdose deaths from their opioid use disorder, underlying opioid use disorder using buprenorphine, but also one could help patients stay on their medications, their antiretroviral therapy, adhere to those medications, and achieve and maintain viral suppression. So this was a study that myself and colleagues undertook in patients living with HIV coming out of prison and jail specifically, all with opioid use disorder. And it was a prospective study, a non-randomized control trial, and basically it was right after the FDA-approved buprenorphine to be used, and we just wanted to see if patients would accept it, and the primary outcome was to look at would this improve their likelihood of maintaining viral suppression. Just a caveat, prior work had shown that roughly only 18% had maintained viral suppression after release from prison, after achieving viral suppression. So maintaining viral suppression after 3 months would be a substantial benefit. In this population, although it was only roughly 100 individuals, what we found is that those who were started on buprenorphine in dark green and maintained on buprenorphine for a total of 6 months after release had a statistically significantly higher proportion with viral suppression at less than 50 copies per milliliter, upwards of 80%, compared to those who were initiated on buprenorphine but couldn't stay in the orange. And those who were not on buprenorphine chose not to have any treatment or methadone alone. In addition, just retention on buprenorphine had an odds ratio of 5.3 in predicting likelihood of maintaining viral suppression in combination with antiretroviral therapy. Similarly, we were interested in utilizing another medication, which is extended-release naltrexone, so the injectable medication FDA approved for opioid use disorder, in the same population, individuals with HIV coming out of prison and jail. In this study, this was a double-blind, placebo-controlled trial, and the primary outcome was to look at viral suppression 6 months after release. And this was, as we know, an opiate antagonist, so the prisons and jails in Connecticut allowed us to administer this medication before they were released, and then 5 subsequent months after release, again, roughly around 100 individuals. And the final outcome, as shown on the left-hand side of the graph, those who received extended-release naltrexone improved their likelihood of achieving viral suppression at less than 50 copies per milliliter 6 months out compared to the placebo group, which lost viral suppression. And the odds ratio was around 2.9 in predicting viral suppression if you were administered extended-release naltrexone with your antiretroviral therapy. Additionally, a systematic review and meta-analysis of over 32 studies has shown that any form of medication treatment, methadone, buprenorphine, or naltrexone, was associated with a 69% increase in antiretroviral therapy uptake, improvement in adherence, as well as improvement in viral suppression. So the bottom line is that regardless of the form of medication treatment for opioid use disorder, that treatment for opioid use disorder can improve HIV outcomes in patients living with HIV.
So we're going to expand not just to viral suppression, but many of the other outcomes that the evidence base has really shown us that treating opioid use disorder can give us related to HIV and hepatitis C. So we've got many references on the left-hand side here, just showing all of the different benefits of engaging your patients in opioid use disorder treatment. There's been studies showing reduced HCV transmission, increased HCV treatment uptake and completion, reduced relapse in opioid use disorder, reduced high-risk behaviors for HIV, increased HIV treatment uptake, and decrease in drug-related deaths and drug-related crime. And I don't think anybody can argue that these are all not good things to achieve for our patients. We want them to be virally suppressed for their own health as well as for public health and transmission reasons. We want them to be cured of their hepatitis C, also for transmission reasons and for their own health. And of course, we want them to stay alive, where overdose is really one of the major looming threats for this patient population. Over on the right-hand side, we reference a couple of studies here. The PREVAIL extension study, which looked at HCV reinfection, which is really an important issue, and I think has been used by some providers as a reason why not to treat people who inject drugs for HCV infection. What's really interesting is when you look at the data, such as in this PREVAIL trial here, the reinfection rate is always lower than people expect it to be. So this particular trial found a reinfection rate of just 1.22 per 100 person years. So that's basically between 1 and 2 people for every 100 that you treat. There's a slightly higher reinfection rate amongst those that are actively injecting afterwards, and so among the 19% who reported ongoing drug use, the reinfection rate was a little higher at 7.4 per 100 person years, but still a very, very small number. There's been other studies showing that the range is around 5 per 100 person years. And interestingly, there's a couple of factors that do predict who is more likely to be reinfected. And so one of those interesting things is the use of opioids plus stimulants is actually associated with a higher risk of HCV reinfection rather than just injecting opioids alone. So Sandy, why do you think that is, that stimulants may play a different role here in terms of reinfection?
I think there's a couple of things. One, medication treatment for opioid use disorder does not treat stimulant use disorder. Unfortunately, we do not have a magic treatment, and it's unfortunately pervasive, methamphetamine, cocaine throughout this country. But I do believe that partly, as the authors found in the extension trial of PREVAIL, that if you looked at specifically what was driving the new infections in those who had cure from hepatitis C in people who are continuing to use drugs was not the opiates alone, but it was the stimulants combined with the opiates or stimulants alone So one of the things that, in addition, would be that we have to talk about harm reduction services, syringe service, clean needles, clean works, clean technique in discussing cleaning one's skin to reduce other harms related to injection drugs. So thus, it's not a failure of medication treatment for opiate use disorder. In fact, it's been found to help, as you had said, in multiple ways and help this particular population. But we also have to evaluate for other comorbid substance use disorders like stimulants to help provide harm reduction services and other behavioral treatments that might be helpful for them.
Yeah, and I think this case and this discussion really highlights the fact that we should get a really detailed history of what people are using. And if you're new in this area, I certainly in medical school didn't get that much training on how to talk to people about sex or drugs for that matter. But I think taking a really curious approach, really kind of a welcoming approach to people to find out what they're using can actually help us tailor our treatment. Has that been your experience as well?
Yeah, absolutely. And I think about whenever I see a patient asking questions in a non-judgmental way, an open answer, and a non-punitive way as well. And just like we take care of patients with HIV, we should not be asking questions in a judgmental way. And I think this allows one to answer freely and feel safe and to have a trusting relationship so that you can move forward and meet the patient where they're at.
Yeah, and I'll just say from a provider perspective as well, many patients elicit kind of some defensiveness from the provider, especially with regard to opioid use disorder. Are they going to want me to prescribe them an opioid before they leave today? And is it going to be an antagonistic visit or antagonistic relationship? I certainly didn't go into medicine to be starting fights with people. We went into this to help people. And just making that shift, it's a really easy shift, a slight shift in your perspective, that you're just here to help somebody, you're just curious, you don't want to make things antagonistic. It really helps actually reduce burnout, I think, even dealing with this population as well.
Yep, absolutely. So not just the American Society of Addiction Medicine, but also Infectious Disease Society of American HIV-MA, as well as National Academy of Sciences, Engineering, and Medicine, have all requested that there should be a call to action. In particular here, we're highlighting a recent workshop in 2018 by NASAM, which actually called for integrating opioid use disorder treatment, infectious disease screening, and treatment. And subsequently, another paper that was published that I co-authored identified 5 main action steps that can help, and basically what we've already discussed, but providing opioid use disorder treatment and screening in healthcare settings, across all healthcare settings associated with HIV, hepatitis C, as well as other infectious diseases. And then if you do identify individuals with an opioid use disorder, providing immediate access to treatment as well as opiate withdrawal symptom treatment, and helping to enable new hospital-based protocols, other discharge protocols to help linkage in the community, and also improving education across all treatment providers, not just infectious disease doctors, but everybody and students, and increasing access to healthcare and state funding for opioid use disorder treatment, much like we were discussing a Ryan White care model for HIV, but a Ryan White care model for opioid use disorder would be beneficial.
All right, so we alluded to this a little bit before, but I want to talk about just what this has meant to us in our own practices. And I'll start by saying that one of the biggest anxieties in medicine to me has always been if you didn't know what to do in a certain situation. That kind of creates anxiety from the provider perspective. And this is an example that in my practice, it's felt really comforting to me and feels really good and taps into the compassion that really brought me into medicine to be able to know what to do in this situation. You have a person who comes to your care, I know how to treat their HIV, I know how to treat their hepatitis C, but having that gap in my knowledge of what do I do about their addiction, because that's maybe even their biggest problem, it's been very satisfying to learn how to do this and to actually to provide that level of care to the people that need it. How about you?
Absolutely the same thing. And for me, not just when they're in the throes of actively withdrawing from opiates, when you can provide buprenorphine first is like probably one of the most satisfying things I've ever done. So if you've ever witnessed someone agonizing through opiate withdrawal. It's probably one of the worst things I've ever seen. And then to quickly turn it around with buprenorphine treatment, it's probably the biggest boon to primary care. But secondly, the other population is those who are not actively utilizing drugs but are at increased risk for relapse. And so the other population, as I mentioned before, is the criminal justice population, and the number one cause of death for that population, regardless of how long they've been incarcerated, is opiate overdose. And so if I could provide treatment to that population before they get released so that there's a safeguard on board, is very, very satisfying. And patients have a high acceptability and are actually quite happy that someone's actually even brought it up, because it is a big fear when they get out that they are going to be released to the same environment and don't want to get into the same situation.
What does this look like in terms of systems of care in your practice? Probably in the past, people would have had to refer out to psychiatrists to handle this, and what does it look like now?
Yeah, so I'm in a couple of different treatment settings. So one is the VA healthcare system. Other is doing work in the community. But in the VA healthcare system, they do have both clinicians in separate settings, but within the whole system that can see patients and treat opiate disorders. So you could refer, but you also now, there's a huge initiative for primary care doctors, other specialists to also provide opiate disorder treatment on site. And I find that very beneficial, and patients actually really like it. Even if it's, one might not think it's that big of a deal to refer to a specialist, it's in the same building. But for my patients, especially those living with HIV, going to see another doctor or another clinician is a huge burden to them, and making another appointment, telling their story all over again. So if I can do both at the same time and alleviate some of that stress and that anxiety of seeing another provider, then I found that really quite satisfying.
Yeah, we've gone over some of the data, and the outcomes really are certainly there. And I'll just say anecdotally, from a patient perspective, to go to one single place and get your HIV treated, get your hepatitis C treated, and get your addiction treated is really efficient for the patient. The way we've tackled it in our setting, which is an FQHC or a primary care center, is that really all of our primary care folks are HIV certified, and they're also all X-waivered. We certainly have specialists. I'm an infectious disease specialist, kind of helping to oversee things, and we have an addiction psychiatrist that's available for consultation as well. But really, all of us are basically cross-trained, and it really respects that patient-centered model and patient-centered medical home. I will just say one other point here, which is that infectious disease doctors are really well equipped for this type of problem. Many of my mentors when I was training really got pulled into HIV because they were residents at San Francisco General Hospital or Bellevue in New York City, and just got sort of pulled into this health crisis as a way that inspired them throughout their careers. And even just looking at the sheer numbers, where at the peak of the HIV epidemic, I think the most people that died in a given year was 49 or 50,000 a year. And we're actually well past that in terms of overdoses related to opioids that we see per year. So many younger clinicians, younger infectious disease docs are really feeling pulled in to this as a part of their practice.
Absolutely, and it reminded me that this is why I went into HIV, because in the Northeast, the HIV epidemic was really fueled by injection drug use and heroin, as well as crack cocaine, and affecting mainly African American and Latino men and women. And just watching them die alone, so there was this sheer stigma from having HIV, but on top of that was substance use. And you just reminded me of something that I feel is really compelling, is the stigma that I see, and I talk to other clinicians, related to opiate use disorder and other injection drug use or other substance use in general, is far worse than the stigma that we saw in the early epidemic from HIV. And not just from patients, the stigma that they're seeing in the community, but in providers as well, not wanting to treat. And I really think, like you said, this Ryan White care model that we have discussed several times, but in clinicians who, young ID doctors getting pulled into this, I think are witnessing what I witnessed early on, but more from the pull of addiction as opposed to HIV.
Yeah, we've seen the Ryan White care model, how effective it is at addressing these social determinants of health and these psychiatric, mental health, and addiction related problems, and we've seen it work with good HIV outcomes. We can certainly apply it to other populations.
Great. Thank you very much, Dr. Springer and Dr. Ramers, for that insightful discussion, and thanks to listeners for joining in. As a reminder, to view the full online educational program, Navigating the Nexus of Addiction, HCV Infection, and HIV Infection, on the Clinical Care Options website, click on the link in the show notes. And please be sure to check back regularly for more episodes on important infectious disease topics. Thanks.